Hello and welcome to the MEDSURG Nursing Journal podcast series. This series provides extended content relating to articles published in the journal, such as author interviews and roundtable discussions. Before we get started, we have a special offer for our listeners. You can save 50% off 1- and 2-year subscriptions to MEDSURG Nursing, the official journal of the Academy of Medical Surgical Nurses. Simply visit medsurgnursing.net/offer to take advantage of this special discount. In this episode, MEDSURG Nursing Journal Editorial Board member Dr. Cynthia Ward, a surgical clinical nurse specialist at Carilion Roanoke Memorial Hospital in Roanoke, Virginia, talks with Dr. Donna Bond, a clinical nurse specialist at Carilion Clinic in Roanoke, Virginia. Dr. Bond is a founding member of the Virginia chapter of Clinical Nurse Specialists and served as the first president. In addition, she is an active member in the Respiratory Nursing Society Interprofessional Collaborative, serving in multiple board positions, including president. Other organizations where she has contributed her time are Sigma Theta Tau as a founding member of Tau Phi and the American Association of Clinical Care Nurses. She currently serves on the national board of the Respiratory Compromise Institute, representing the clinical nurse specialist role as one of 2 nurses on the board, and represented the clinical nurse specialist role and Respiratory Nursing Society on the National Concert Workshop to determine priorities for patients with chronic obstructive pulmonary disease. Dr. Bond carries certification as a critical care clinical nurse specialist, certified asthma educator, and certified tobacco treatment specialist. Recently, she was inducted into the first class of fellows at the 2019 Annual National Clinical Nurse Specialist Conference. Dr. Bond has presented at many national conferences as both a speaker and a poster presenter. She has also been published for her work with adolescents in tobacco prevention, asthma education, and the clinical nurse specialist role. This discussion focuses on respiratory compromise. Dr. Bond provides information regarding why respiratory compromise is of concern for MEDSURG nurses, the importance of awareness of respiratory compromise to help reduce adverse events and patient deaths, how MEDSURG nurses can increase their awareness through recommendations, clinical education, and training policies that should be put in place to guide nursing practice, and the role of MEDSURG nurses in treating patients with respiratory compromise. We are pleased to present Dr. Ward's interview with Dr. Bond.
Hello, I'm Dr. Cynthia Ward, a member of the MEDSURG Nursing Editorial Board. I am pleased to welcome Dr. Donna Bond, clinical nurse specialist at Carilion Clinic. Donna represents the National Association of Clinical Nurse Specialists at the Respiratory Compromise Institute. Donna, welcome to this episode of the MEDSURG Nursing podcast series.
Thank you for inviting me.
Our topic today is the role of nurses in recognizing the signs of respiratory compromise and preventing opioid-related adverse events. Donna, could you tell us a little about your background, what respiratory compromise is, and your involvement with the Respiratory Compromise Institute?
Sure. I have been a registered nurse for 36 years. In the last 20 years, I've been a clinical nurse specialist with a special interest in the care and the prevention of pulmonary disease. I received my doctorate from Case Western Reserve University and have certification in critical care, asthma, and smoking cessation. I am currently employed by Carilion Clinic. We are a 7-hospital system in Southwest Virginia. The main hospital has a Level 1 Trauma Center designation and a 50-bed neonatal intensive care unit. We care for patients throughout Southwest Virginia and the neighboring states of West Virginia and North Carolina. With my interest in pulmonary and patients with pulmonary disease, respiratory compromise was a natural fit for me. Respiratory compromise was formally defined as a group of patients that have one or more of the following issues. They may have impaired airway protection, impaired control of breathing, parenchymal lung disease, increased airway resistance, or hydrostatic pulmonary edema, right ventricular failure. These patients with unstable pulmonary health can be found across the healthcare continuum, and it carries a high likelihood of respiratory failure or death. Respiratory compromise is the second leading avoidable patient issue in the United States and the 5th top condition that increases hospital cost. In 2007 alone, $7.8 billion, that's with a B, was spent on respiratory compromise in the United States. It has been estimated that more than 60% of arrests due to respiratory compromise are avoidable. The Respiratory Compromise Institute is a group of 12 professional medical societies and interested healthcare providers that formed in 2015 to define respiratory compromise and educate the healthcare community to reduce this preventable risk of harm and death. I was appointed by the National Association of Clinical Nurse Specialists to represent the CNSs, and since I am one of only 2 nurses in this group, I represent nursing in general. We promote education by attending and presenting at conferences, developing podcasts such as this one, and publishing articles and conducting research on respiratory compromise.
Why is respiratory compromise a concern for med-surg nurses?
Well, respiratory compromise, if you remember from what I said just a few minutes ago, can be related to impaired airway protection and impaired control of breathing. Both of those issues are related to the administration of opioids. On the med-surg unit, many opioids are given with minimal monitoring of the patient. Oximetry is a way of providing minimal monitoring. It monitors only the oxygen saturation of the blood. And if the patient is wearing oxygen, there's a delay in the alarm with respiratory compromise. This delay may result in injury or death. Impaired control of breathing is best monitored by assessment of ventilation. This is done by careful nursing assessment of the respiratory rate, and it can also be monitored by end-tidal CO2 monitoring known as capnography. Elevations in CO2 can be identified hours before changes in the oxygen saturation are identified by an oximeter. And if you're doing spot checks of oximetry alone, you will not pick up on the subtleties of respiratory compromise until late in the process.
Donna, do you think that greater awareness about respiratory compromise may reduce adverse events and patient deaths?
Absolutely. The respiratory rate is the only vital sign that we are still not able to capture by machine. Nurses and other healthcare professionals must accurately, manually count the respiratory rate. Accurate counting requires a full minute of counting. There should not be a 15 or a 30-second count and then multiply by 2 or 4. Respiratory rate is such a sensitive indicator of compromise that a difference of 1 or 2 respirations per minute can indicate impending tragedy. I don't think that nurses know that respiratory rate is a more sensitive indicator of impending complications than monitoring the heart rate or the blood pressure. Yet, respiratory rate is often missing or incorrect. We tend to observe the patient and assign a respiratory rate. If you have an early warning system in place at your hospital, and then you put in an inaccurate respiratory rate, you may negate the usefulness of the system. So this basic nursing skill is very important in the assessment of the patient's respiratory status. Also, the opioid crisis and just more people using opioids increases the risk of respiratory compromise.
What do you think could be done to make nurses more aware of the dangers of respiratory compromise? Is it more recommendations, clinical education, training?
All of the above. I believe we need to begin with education but not stop there. Nurses have many demands on their time, and counting respirations for a full minute is not currently valued. I think many of us have forgotten that respiratory rate can be the warning sign that something's going wrong with our patient. We need to show nurses the research about the value of an accurate respiratory assessment. At this time, many routine monitoring of vital signs are done by machine. But so far, nurses counting respiratory rate has not been replaced by a machine. That said, there are machines that can help nurses, such as the end-tidal CO2 monitoring or capnography, and we should put policies in place to guide nursing practice.
What policies and procedures would you recommend?
Well, the NACNS supports the Center for Medicare and Medicaid Services proposal to include safe use of opioids in their clinical quality measures. These measures are needed to assess opioid follow-up, prescription, and appropriate prescribing. Here at Carilion and throughout the country, the CNS leads efforts to modify the use of opioids for pain relief, to implement protocols for alternative pain management, and to provide individual pain consultation for pain management. In addition, the NACNS has appointed an opioid pain management task force that is developing tools and resources to assist healthcare providers to improve the management of pain and enhance the correct use of opioids and other pain management options. We also stand with the Anesthesia Patient Safety Foundation, the Physician-Patient Alliance for Health and Safety, and the American Society for Pain Management Nursing, who all support close monitoring of the patients receiving opioids with capnography. The NACNS has also recently published a position paper that supports a balanced approach to the care of patients in pain. We still want to treat the patient's pain, we just need to monitor them carefully. We know that more than 2 million Americans have an opioid use disorder, but less than 20% of those people receive appropriate treatment for this disorder. And appropriate treatment includes access to medication-assisted treatment, including naloxone and community-based programs and training.
What role should nurses play in assessing their patients when opioids or other sedatives are administered? For example, PCA pumps are commonly used to manage pain following surgery. What standard procedures would you recommend nurses take to assess patients before administering PCA and for continuing PCA administration?
At my hospital, the CNS initiated a policy for monitoring capnography in all patients receiving PCA analgesia several years ago. We follow the American Society for Pain Management Nursing guidelines on monitoring for opioid-induced sedation and respiratory depression. There are similar risks for PCA and IV push medication administration. The nurse needs to consider the individual patient characteristics such as age, type of surgery, and the patient's prior exposure to opioids. Is the patient opioid naive or opioid tolerant? In addition, the family needs to be taught that they're not to, quote, help the patient, end quote, by administering extra doses of the medication. PCAs with basal rate, and if the nurse is rapidly titrating the medication dosage up, increases the patient's risk of respiratory compromise. Also, concurrent medication administration of antihistamines, benzodiazepines, and even the anesthesia the patient received during surgery can also increase their risk of respiratory compromise. I would recommend a comprehensive assessment of the patient when administering PCA, opioids, or any sedative medications. This includes the patient's reported level of pain intensity, their level of sedation, the adequacy of ventilation. And adequacy of ventilation includes the depth and rhythm of breathing, work of breathing, use of accessory muscles, symmetrical chest movement, and breath sounds. Also, you must include their 1-minute counted respiratory rate. At Carilion, we used evidence-based instruments to assess pain and sedation. We used the 1 to 10 pain scale, the Passero opioid-induced sedation scale for unintentional sedation, and the RASS, or Richmond Agitation and Sedation Scale, for intentional sedation. I personally believe that closer monitoring of patients receiving opioids by any means of administration, including by mouth, should be monitored more closely.
Would you recommend that patients receiving PCA be continuously electronically monitored?
Absolutely. Patients using PCA pumps should be monitored with capnography. This is a national standard. Capnography assesses both perfusion and ventilation. It's more sensitive and is an early indicator of respiratory compromise. Each hospital should follow the standards set by the American Society for Pain Management Nursing.
Nurses on MEDSURG units typically care for 5 or more patients per shift. Could high patient-to-nurse ratios or the shortage of nurses be a patient safety concern?
Yes, both the nursing shortage and the higher patient-to-nurse ratio will continue to affect patient safety. There have been studies that show a well-trained nursing staff prevents adverse events such as respiratory compromise. Did you know that sedation and respiratory depression is the second most reported adverse event in hospitals according to the Joint Commission? And there's also an increase in the length of stay and cost due to respiratory compromise. Respiratory compromise on the med-surg floor, adequately trained staff could intervene sooner to decrease length of stay, decrease cost, and decrease adverse events.
How might technology, and particularly patient monitoring, help nurses in providing patient care?
Capnography monitoring of patients would help the nurse when he or she cannot be at the bedside. It provides early indication of respiratory compromise by assessment of decreased central respiratory drive, diminished chemoreceptor responsiveness, decreased airway tone, and more quickly picks up respiratory compromise than oxygen desaturation, which you would find on an oximeter, or diminished chest excursion.
Can you talk a little bit more about oximetry? Some hospitals monitor patients receiving sedation just with continuous pulse oximetry. What do you think of this practice?
I believe that monitoring by machines will never replace direct nursing observation and assessment, but we must use technology to supplement the nursing assessment. Pulse oximetry has been the subject of a Cochrane review, and that Cochrane review found while it is capable of detecting hypoxemia, it is limited because it cannot assess ventilation. The patient can have a high O2 level and still have respiratory compromise. Oximeter spot checks, as opposed to continual monitoring, can also stimulate the patient to have a higher reading at that particular moment in time, and then they will drop their oxygen saturation down as soon as you stop stimulating them. Also, darker-skinned patients can produce false high oximetry readings.
So what advice can you give med-surg nurses to recognize and prevent respiratory compromise?
Count your patient's respiratory rate for 1 full minute. Do not multiply by 2 or 4. 1 full minute. Consider each patient's potential for respiratory compromise and put safety measures such as capnography in place to prevent respiratory compromise.
Are there any last words of advice that you would like to give to hospital executives on why they should be aware of respiratory compromise?
Not monitoring patients for respiratory compromise affects patient outcomes and ultimately the healthcare bottom line in monetary cost and the cost of morbidity and mortality. You may learn more about Respiratory Compromise Institute at www.respiratorycompromise.org.
Donna, thank you so much for joining me on this podcast, and hopefully clinicians and hospital executives out there will listen to this and implement closer monitoring of the patient's respiratory rate and use technologies such as capnography in their own facilities.
Thank you.
The MedSurg Nursing Journal podcast series is owned and produced by Genetti Publications, Incorporated. All rights reserved. No portion of this podcast may be used without written permission. Dr. Donna Bond is a clinical nurse specialist at Carilion Clinic in Roanoke, Virginia, and is an active member in several nursing organizations, including the Virginia chapter of Clinical Nurse Specialists, the Respiratory Nursing Society Interprofessional Collaborative, and the Respiratory Compromise Institute. Dr. Cynthia Ward is a surgical clinical nurse specialist, Carilion Roanoke Memorial Hospital in Roanoke, Virginia, and is a member of the MedSurg Nursing Journal Editorial Board. For archived episodes of this podcast and to learn more about MedSurg Nursing, visit the journal's website at medsurgnursing.net. You can also subscribe to the MedSurg Nursing Journal podcast anywhere you get your podcasts, including iTunes, Google Play Music, Google Podcasts, Spotify, Stitcher, TuneIn Radio, our hosting site Spreaker, and more. And remember, as a listener, you can save 50% off 1 and 2 year subscriptions to MedSurg Nursing Journal. Simply visit medsurgnursing.net/offer to take advantage of this special discount.